Thank you so very much, Barry, and a very gracious thank you to the Society for the very kind invitation to share some thoughts on something that's really kept us totally engrossed in the last 20 months to 2 years. I'd also like to take this opportunity to thank all the sponsors and to Sandoz as well for specifically sponsoring this talk. And I'd like to commend all these speakers on absolutely outstanding talks this morning. I'm going to run through in the next 10 to 15 minutes, 10 different issues. And they're going to really, if we have a look at the topics, sticking to the T's, give you a brief description of what the last 20 months has been like, reiterate the current situation, which many people have alluded to, but just put it into perspective, look at the essentials and the general management principles that have evolved after having spent 20 months and looking after hundreds of critical care patients with an absolutely wonderful and outstanding team. Look at some of the issues of triage and ethics, touch on some of the therapeutics. Where are we after 20 months and what are some of the insights? Briefly touch on some of the other aspects from a pragmatic perspective that we've learned, touching on important issues of staff, the impact overall, very briefly allude to vaccination and then conclude. And so if we look at the last 20 months, liking terminology and wordplay, this has been a very taxing, a very trying and a tantalizing time. It's been eerie, educative and enthusing, intrusive and illuminating, as well as, in fact, inspirational at times, but demanding and distinctive. If we look at things overall, for me, it's been a very rewarding time and one that's required a lot of reflection. And I think that's the context of what we're going to share today. The multiple lessons that we've really learned from the challenges of COVID-19, from our own personal experience, from those around regionally and locally, as well as the global experience. So where do we stand? And these are the stats as of, in fact, this morning. 250 million people affected in the last 2 odd years, 5 million deaths. And Derek, what that does in terms of perspective, COVID is now the 3rd most common cause of death in the world, following heart disease and stroke. And in South Africa, close to 3 million coronavirus cases and close to 90 million deaths. And we are having a little bit of a lull at the moment, but in Europe, there's been a marked resurgence. And I think that's a very, very important lesson for all of us to take out. In fact, in the last 4 weeks, I know Sylvia is online, in Germany, 55% increase in the number of cases in Europe in general. And on Wednesday in Germany, close to 34,000 cases. So we should not drop our guards. This is a very important issue, and it's an ongoing issue. So what are some of the essentials in a nutshell that we can take out that we've learned in the last 20 months? The first is obviously you've got to prepare adequately. The second is communication at all levels is absolutely paramount. That is with staff and family, and it's got to be done in a suitable fashion. And the way I like to look at it is in the context of Ubuntu, that wonderful African philosophy. And in fact, we've just put that into print, and the term has been tweeted around the globe because of its connotation. In other words, being compassionate, being kind, and being humane, whether we're talking and speaking and communicating with families, with patients, or with our own colleagues. We have to be kind to each other. Staff protection from a safety perspective, as well as a psychological perspective, incredibly important. And we need to know that we need to be flexible and adaptable. If we knew it all up front, it would be easy. That's why, in general, things in a lifetime, it's referred to as life experience. And then one of the most important things that I've found, which should be a principle underpinning every bit of medical practice that we engage in, and that is sound clinical acumen. We shouldn't be treating a chart or a computer whilst the patient lies in the bed. You pick up things, even if they're COVID positive individuals. Continuous assessment is essential. You cannot come in for 2 minutes in the morning and 2 minutes in the evening, treat the chart or the computer, look at results, and hope that things will settle. You have to intervene and be there all the time. And it's one of the reasons that possibly our outcomes have been inordinately better than anywhere else in the country, despite having probably a very severe spectrum of disease. In fact, that was the only spectrum that we could in fact take. Do the simple things well. An adage that I've been trying to promote for many years and that has now been adopted. If you do the simple things well, you're likely to have a successful outcome. And be patient. It takes time for diseases to evolve, and similarly time for those diseases to resolve. And in fact, many patients who would have been written off up front that we battled with had successful outcomes because we were patient. Treat the patient and not just the numbers. So what about the general management principles and things that certainly I've learned and that have come out of the unit where I've been in and that we've shared on broader scales and with very broad interaction, even on a global basis. And the first is early intervention is absolutely essential, be it for milder disease or in the spectrum that I'm going to focus on more predominantly, the more severely ill patient. The earlier we can get in, the better the outcomes. And in the early days, we were told, don't ventilate these patients. If you ventilate them, the outcomes are poor. And a lot of that data came from first world countries where many of the critical care specialists, intensivists, not familiar with ventilating large numbers of patients. In the US, you have respiratory therapists who are involved in that. And suddenly, the clinical practitioners were having to do it, and there were inordinately high mortalities. One of the things that we learned is don't allow the patients to become exhausted. If you do and you then intubate them, in fact, you confer a more deleterious outcome. So we would offer appropriate oxygen support, perhaps high-flow nasal cannula support, perhaps non-invasive ventilation. Patients are not doing well relatively quickly. We intubate and ventilate them, and that infinitely has improved outcome. One of the major cautions is the airway management, a massively important thing to be aware of. And we were caught out on many occasions. These airways can be exceedingly tricky. And on some occasions, you need to have alternatives for airway management, including laryngeal masks, very skilled airway management individuals. And we in fact had to do cricothyrotomies and even urgent tracheostomies in some of the patients. In terms of the mechanical ventilation, very simple elements. Lung protective strategies, keep the pressures, the intraalveolar pressures below 30 centimeters of water. The initial entities of giving high peeps are not necessary at all, and keep the tidal volumes relatively low in the region of 6 moles per kilogram. One of the big entities that I think has changed issues and largely emanated from our setting where we've been doing airway pressure release ventilation for 10 or 12 years. And I must say, I thought I knew something about this mode of ventilation, but the last 20 months, I've learned an absolute fortune about it. There are nuances, and I have no question of doubt that when used correctly, this changes outcomes. In fact, many people who would land up on ECMO, when used appropriately and upfront, together with the other measures, I think you can avoid those issues and very often confer a successful outcome. Another thing that I think has revolutionized COVID management was something that also emanated out of the state sector. In fact, we helped design some of these so-called wall CPAP devices, which I think are far better than high-flow nasal oxygen. And if people do not have an opportunity to get into an ICU, we can offer them something that has also been associated with improved outcomes. So I think really a revolutionary intervention that evolved with the second wave. Tracheostomy. If you have a look at international guidelines, they'll tell you, wait, once the patient's settled, you can consider tracheostomies. Our adage and our teaching and our learning and our experience over some very arduous months was, if you are dealing with a difficult airway, go ahead and do a tracheostomy early on, because if you lose that airway, you often lose the patient. So you want a secure airway. And obese patients who may inherently be difficult to intubate, and if you lose that airway, same story. And our results there were infinitely better. We've heard a lot about awake proning. That's turning people onto their tummies whilst they're on oxygen support devices, face mask, nasal cannulae, or other devices. And in fact, it struck me one day, why are we getting them to turn onto their tummies when that is quite exhausting? And it makes sense for them just to sit or stand. Gravitationally, you get better expansion of your lungs. And one of the first patients that struck me with was one of our own nursing staff, ICU nursing sister, who had severe COVID pneumonia with saturations of 30%. And we started doing all these things. And in fact, this patient survived and is working in the unit currently. I've shared these sentiments abroad as well. And in fact, to a lot of excitement, and it makes a lot of sense. Stringent infection prevention and control measures. There have been breakdowns in tight infection control across the globe. We're seeing problematic pathogens, and we need to not lose sight that we need very tight infection prevention control measures. And not all of us have adequate negative pressure facilities. And one of the things, again, shared from our own unit was that just open the windows. You get 6 to 12 wonderful air exchanges per hour, better than most negative pressure facilities. And again, this is taken off globally. What about triage and ethics? We live and work in a resource-limited country, and the vast bulk of our population only have access to resource-limited services. But everyone with COVID was resource-limited. And so it didn't matter whether you were in a high-income country. And so you have to triage, sadly. And how do you do that on an ethical basis? And some years ago, I formulated an entity called the R's. And the R's, very useful in terms of assisting one to decide who should come without negating anything that a patient should and does deserve. And those R's effectively are, is there rationale to admit the patient to your unit where there may be limited beds? I'm talking ICU. Is it reasonable? Is it responsible to do it? Is it realistic? In other words, you've got full beds, may not be realistic. And if you can have yeses to the rationale, the reasonability, the responsibility, and whether it's realistic, you have made the right decision. And if you cannot admit those patients, you go back so that no one is denied, you reevaluate them, you reassess them, you reconsider. And what we did, we often offered those that were not deemed suitable wall CPAP, and around about 25% of them, in fact, survived. End-of-life care has to be performed with dignity and decorum. There are massive numbers that everyone was dealing with, and it's very important that dignity and decorum is not lost. And similarly, futility, when in fact there is no way forward, it actually is ethically unreasonable to add to the misery, to the pain of the patient and their loved ones, and also to deny others an opportunity who may benefit whilst the bed is being taken up. And then the other big issue we learned with CPR, if patients in fact do have cardiorespiratory arrest as a result of progression of the disease, it is pointless trying to do CPR. In fact, all the data put together suggests less than 1% success. So what about some of the therapies? And there are literally thousands of papers. What should we be doing now? What do we advocate in an objective fashion? And the first thing is corticosteroids. And this is the only thing that has been definitively was the first thing to show that there was definitively a mortality benefit for hospitalized oxygen-dependent patients, 20% reduction in mortality. If you were ventilated, a third reduced mortality, which was really significant. I've been a huge advocate all along, and my wonderful staff will bear that I'm not keen on these high doses of steroids that are being dished out. I think they actually create problems. I think they select out for infection and various other issues. And so from the outset, we used only moderate doses. We used it long before the data was out there in exactly the same dose as was shown in the recovery study. And in fact, yeah.
Sorry, Merv, you need running out of time. Merv,
yeah.
you need to just 2 more minutes, please. Sorry.
I'll just share a few relevant issues, Barry. Just on that note, you don't need more than 6 to 8 milligrams of dexamethasone. Big study just come out corroborating that doubling that dose makes absolutely no difference. Tocilizumab, essentially reserved for those already on steroids. First 24 hours following admission to ICU, and the absolute risk reduction in mortality, 4%. Anticoagulation, controversial. Most guidelines, in fact, suggest prophylaxis only. If you're severely ill, we fully anticoagulate, and we target factor anti-10A levels 0.6 to 0.8. No antibiotics up front. There's no evidence for vitamins. Ivermectin, there's no clear benefit. And in fact, in a very recent, just a few days ago, NEJM publication associated, in fact, not infrequently with severe side effects neurologically, remdesivir given early, brand new paper, decreases mortality, and colchicine we think may have some benefit in the long term. These are other elements that are really relevant. I'll just point out 1 or 2. Pneumothoraces, be aware of, occur with far greater frequency. If you are going to use ECMO, early intervention before multi-organ failure. Be aware of your staff. Burnout is an excessively important thing. We've all shed tears together. Having worked extensively and intensively on patients, and remember, everyone hurts. Support staff psychologically and beyond. One of the most important, impactful things has been, it's brought to the fore the relevance of critical care. Remember, it's a privilege to be in this profession. We can make a difference, and we can return people to life, and the living years are important. And so nothing is impossible. We will continue to learn. And lastly, from a vaccine perspective, bottom line, we need to up that. Only 6% of Africans have been fully vaccinated, as opposed to more than 40% in the bulk of high-income countries. And there the figures are, we need to encourage, educate, and implement definitively. You prevent severe disease and death. And then finally, in conclusion, just a real tribute to all healthcare workers out there. You are the courageous champions of care. You are the real heroes. Everyone deserves to take out a kudo there, and also our thoughts with all those people who've lost loved ones. And so for the heroes, know that a hero lies within you.